frequently asked questions about difficult to control or resistant hypertension. What is the difference between resistant hypertension and difficult to control hypertension? Resistant hypertension is defined as blood pressure above goal despite adherence to a combination of at least 3 optimally dosed antihypertensive medications of different classes. However, in reality, it can be hard to tell if a patient is truly adherent to an optimally dosed 3-drug regimen. Therefore, patients with drug-resistant hypertension are considered a subset of those with difficult to control hypertension. How can optimum blood pressure reduction be achieved with medication? Optimum blood pressure reduction is achieved by combining lower doses of drugs from different antihypertensive classes rather than increasing the dose of a single medication. Importantly, one of the drug classes should be a diuretic. The lower dose combination strategy is also more likely to minimize side effects. What are the causes of apparently difficult to control hypertension? The causes are due to measurement issue, non-adherence to therapy, suboptimal therapy and white coat hypertension. Measurement issues. A cuff that is too small will overestimate a patient's blood pressure. In older patients, severe arteriosclerosis may interfere with accurate measurement. This is referred to as pseudohypertension. If the radial artery remains palpable despite an inflated upper arm cuff occluding the brachial artery, pseudohypertension should be suspected. Non-adherence to therapy. Evaluation of the patient with difficult to control hypertension should begin with an assessment of adherence to the prescribed management plan, including recommended lifestyle modifications. Patients often do not persist in taking their antihypertensive medication due to economic reasons, or they may not understand the regimen because of health literacy, cultural, or language barriers. Suboptimal therapy. The most common reason for failure to reach blood pressure goal is suboptimal therapy. Physician inertia may lead to inadequately prescribed doses of antihypertensives or failure to add additional agents. White coat hypertension. Some patients appear to have difficult to control hypertension based on their office blood pressure measurement, but actually have average blood pressure that is well controlled when assessed by out-of-office measurements. If white coat hypertension is suspected, out-of-office blood pressure should be measured using a validated home blood pressure monitor. 24-hour ambulatory blood pressure monitoring may also be considered. What are the causes of truly drug-resistant hypertension? The causes are due volume overload, interfering substances, obesity, and secondary hypertension. Volume overload. An expansion in extracellular volume is often a contributing factor to hypertension that is difficult to control. Volume overload may be related to a high-sodium diet, chronic renal insufficiency leading to sodium retention, or both. Clinically, this volume overload may not manifest as peripheral edema, and the only clue to its presence may be the persistently elevated blood pressure despite multiple agents, even when one of the agents is a low-dose diuretic. Interfering substances. In addition to dietary substances such as sodium, other exogenous substances can interfere with blood pressure control by directly raising blood pressure, by interfering with the mechanisms of antihypertensive drugs, or both. These include non-steroidal anti-inflammatory drugs, some antidepressants, oral contraceptives, symptomatic, appetite suppressants, and herbal supplements and alcohol. Obesity. Obesity is common in patients with hypertension and may make hypertension more difficult to control because of increased sodium and fluid retention, sympathetic activation, and stimulation of the renin-angiotensin-aldosterone system. Therefore, higher doses of antihypertensive medications are often needed. Secondary hypertension. Chronic kidney disease, primary hyperaldosteronism, and obstructive sleep apnea are some of the more common causes of secondary hypertension presenting with resistant hypertension. The patient should be referred to a specialist if secondary hypertension is suspected. How can pharmacological treatment be further optimized if secondary hypertension has been ruled out? The patient should already be on 3 agents at moderate doses, usually a diuretic, an angiotensin-converting enzyme inhibitor or angiotensin receptor blocker, and a calcium channel blocker or beta blocker. Options at this point include increasing the dose of diuretic or change to a loop diuretic. Other strategies include adding an alpha blocker, alpha-beta blocker, clonidine, or an aldosterone antagonist, for example spironolactone.
Audio Jungle. Audio Jungle.